All right, welcome to the Explainer. Today, we're putting on our detective hats. Our case, the human respiratory system. We're going to uncover the clues it leaves behind. So, picture this. Your patient tells you, "I'm short of breath." It's probably one of the most common things you'll hear, right? But it's also super critical. So, where do you start? We're about to find out how a solid respiratory assessment helps you crack this case and figure out what's really going on. Every good detective needs a toolkit, right? Well, for us, it's not about magnifying glasses and fingerprint dust. Our tools are a set of core techniques that let us gather all the evidence we need. And our investigation follows 4 key steps in this exact order. First, we look, that's inspection. Then we feel, palpation. After that, we tap, percussion. And finally, we listen, auscultation. Each one gives us another piece of the puzzle, and together they give us a really clear picture of lung health. Okay, let's get into it and start gathering some physical clues. We're going to start with inspection, which is really just a fancy word for looking. You'd be amazed at how much you can learn about a patient just by observing them, before you even lay a hand on them. Okay, first clue, the shape of the chest. It tells a huge story. A normal chest, it's wider from side to side than it is from front to back. But look at the abnormal example, the barrel chest. See how it's all rounded out? It's almost like the person is stuck taking a deep breath in. This is a classic sign that air is getting trapped in the lungs, something we call hyperinflation. And you see this a lot in conditions like COPD.
Another thing you can spot right away is their posture. Are they sitting back, looking relaxed, or are they leaning forward like this, in what we call the tripod position, with their hands on their knees? Now, they're not just doing that to get comfortable. They're literally using other muscles to try and force air out of their lungs. It's a huge flashing red sign of respiratory distress.
Okay, now we move on to palpation. That's using our sense of touch. What we're feeling for here is something called tactile fremitus. It sounds complicated, but it's not. When your patient talks, their voice creates vibrations that travel down through their lungs. We can actually feel those vibrations on their back. It's kind of like putting your hand on a wall and feeling the bass from a speaker on the other side.
So what do these vibrations tell us? Well, if there's something blocking the sound waves, like fluid outside the lung or just a bunch of trapped air, those vibrations are going to feel weaker, more muffled. But on the flip side, if the lung tissue itself gets really dense and solid, like it does with pneumonia, it actually carries the vibration better, so you'll feel it much, much stronger. It's a really important clue.
All right, technique number 3 is percussion. This is where we gently tap on the chest and listen to the sound it makes. You know how you can tap on a wall to find a stud behind the drywall? It's the exact same idea. The sound that comes back tells you if the tissue underneath is full of air, or if it's solid or filled with fluid. And you're really listening for one of 3 main sounds. A healthy, air-filled lung makes a low, hollow sound we call resonance. Perfect. But if there's too much air trapped in there, like with emphysema, you'll hear this deep, booming sound called hyperresonance. And if you tap over something dense, like fluid from pneumonia or a tumor, you'll just hear a short, muffled thud. We call that a dull note. Okay, so we've looked, we've felt, and we've tapped. Now it's time for the last step of our physical exam, auscultation. This is where we grab our stethoscope and actually listen in to what's happening inside the lungs. So before we can spot something that's wrong, we have to know what's right. There are basically 3 types of normal breath sounds, and they're supposed to be in specific places. The big takeaway here isn't just to memorize them, but to know that you should hear the right sound in the right spot. For instance, over most of the lungs, you expect to hear those soft, rustling sounds called vesicular sounds. So what's abnormal? Well, sounds could be decreased or even completely absent. That might mean there's a blockage. But what's also abnormal is hearing a sound in the wrong place. If you hear those loud, harsh bronchial sounds way out in the edges of the lungs where they shouldn't be, that's a huge red flag. It usually means that part of the lung has become solid, like with pneumonia.
And then you have what we call adventitious sounds. Think of these as extra sound effects that just shouldn't be there. They're layered on top of the normal breath sounds, and they happen when air has to move through gunk, like secretions, or when tiny collapsed airways suddenly pop open.
The 2 big ones you're going to hear are crackles and wheezes. Crackles sound exactly what they are. Short little popping noises, kind of like Rice Krispies. You usually hear them when the person breathes in. Wheezes, on the other hand, are more of a continuous musical sound, like a high-pitched whistle, and you mostly hear those when the person breathes out. Okay, so everything we've talked about so far, what we see, feel, and hear, it's all qualitative. It's based on our judgment. But to really nail down a diagnosis, especially for something called an obstructive disease, we need hard data. We need numbers to back up our suspicions.
So, the big question is, how do we get that objective proof? How do we go from "I think there's an obstruction" to "I know there's an obstruction"? The answer is a simple breathing test called spirometry. It gives us the hard numbers we need. Let's break down exactly what those numbers mean.
Okay, the first number we look at is called the forced vital capacity, or FVC for short. Here's all it is. You tell the patient to take the biggest, deepest breath they possibly can and then blow it all out as hard and fast as they can. The FVC is just the total amount of air that comes out.
The second number is the forced expiratory volume in 1 second, or FEV1. This one is all about speed. While they're blowing out all that air for the FVC, we measure how much of it came out in just the first second. So FVC is the total volume, and FEV1 is how fast you can get that volume out.
Now this is where it gets really interesting. We put those two numbers together in a ratio, FEV1 divided by FVC. Think about it. In a healthy person, the airways are wide open, so when they blow out, a whole bunch of that air comes rushing out right away, in that first second. That means their ratio should be pretty high, usually over 75%.
But what if the airways are narrowed, like in asthma or COPD? It's like trying to blow through a tiny straw. You can't get the air out very fast. So their FEV1 is going to be low compared to their FVC. If you see that FEV1 to FVC ratio drop below 70%, that's it. That is your objective proof of an obstructive disease. And as a nurse, that's a huge finding you need to act on. From there, we can look at the FEV1 number alone to figure out just how severe that obstruction actually is.
So you've gathered all your clues, you've looked at the numbers, but your job as the clinical detective isn't over once you have a diagnosis. Not at all. The most important part is what comes next. What are you going to do with all this evidence?
So let's do a quick recap of the major red flags. These are the things that should make you stop and say, okay, something's wrong here. A barrel chest or seeing them in that tripod posture, hearing those extra sounds like crackles or wheezes, and of course, seeing that FEV1 to FVC ratio come back under 70%. Any one of these is a clear signal that your patient needs help and you need to take action.
And that really brings us to the whole point of this. You've been the detective. You followed the clues, you pieced it all together, and you figured out what's going on. So now, the most important question is, what's your next move? How are you going to use what you found to make sure your patient gets safe, effective care and has the best possible outcome? Because that is what being a clinical detective is all about.